My name's Reza Fazel. I'm a cardiologist at Emory University in Atlanta. So our group just published a paper defining the determinants of fluoroscopy time for cardiac catheterization and for PCI with the goal of developing some kind of national benchmarks for fluoroscopy time for these procedures. Based on the most recent AHA data, there's approximately 1 million diagnostic catheterizations and about 500,000 PCIs performed annually in the U.S. Just to give some sense, the average reported dose for a diagnostic catheterization is about 7 millisieverts, and that's very close to what a chest CT or the exposure from a chest CT would be. And the average fluoroscopy time for a diagnostic catheterization based on our study is about close to 3 minutes. So there are two key measures that are currently used for gauging radiation exposure from fluoroscopic procedures. The first one is air-kerma area product, and that's basically a measure of the energy delivered from the X-rays to the body, and that can be basically used to determine the risk to the patient, and specifically the cancer risk. The second measure is called air-kerma at the reference point, and that's a measure of peak skin dose, and that can be followed to determine whether the patient's at risk for skin injuries that fall within what we call the deterministic effects of radiation, where there's a predictable dose response, and if those thresholds are breached of certain skin doses, you can get erythema, and with higher doses even ulceration and skin breakdown. So we use the Cath PCI registry, which is was developed by, it's part of the National Cardiovascular Data Registry, and was developed by the American College of Cardiology in conjunction with the Society for Cardiac Angiography and Intervention. And it's basically a repository of information related to catheterizations performed at over 1,000 hospitals across the U.S. And so the distributions of fluoroscopy time for both the diagnostic angiography and PCI were close to a normal distribution, but somewhat skewed to the right, as expected. And obviously fluoroscopy time with bypass grafts for both procedures were longer than patients who had not had prior bypass surgery. So for diagnostic catheterization, the factors that were associated with the greatest changes in fluoroscopy time, the increases in fluoroscopy time, were one, procedures being performed at a university hospital, and we believe that's related to involvement of trainees, and that's been described for other similar fluoroscopic procedures as well. Other factors were radial or brachial access were associated with longer fluoroscopy times for diagnostic catheterization, and any concomitant procedures such as right heart catheterization or balloon pump insertion. For PCI, again, university hospital setting was associated with longer fluoroscopy times. Any sort of complex lesions, interventions on complex lesions, as expected, were associated with longer fluoroscopy times, as were any complications like dissection or perforation. And radial access and brachial access were also associated with longer fluoroscopy times for PCI. So with longer procedures, typically more contrast is also being used, and the higher the volume of contrast, the greater the risk of renal damage. So I think there's, the hope is that this paper will help in two different ways in terms of increasing the radiation safety. One is to increase awareness of operators of the measures of radiation exposure and trying to pay attention to those. All fluoroscopy machines manufacturer since 2006, actually display in real time both of those measures that we discussed, the air kerma area product as well as the air kerma at the reference point. And I think one of the goals of the paper is to increase visibility of these measures and educate operators what they are, and to help them kind of understand what they're, to follow those on the screen. And there are other specific measures that operators can use, and we create a list at the end of the paper to discuss those. And some of the key ones are trying to keep the patient as close to the image intensifier and as far away from the X-ray source as possible during the procedure, using collimation, which basically narrows the exposure of the patient to radiation exposure only to the parts of their body that are relevant to the imaging. Use of wedge filters when appropriate, using the lowest frame rates for both fluoroscopy and for cine during the procedure. And a lot of the machines, fluoroscopy machines these days, also have last image hold and loop displays where fluoroscopy clips can be stored in place of cine images when appropriate. And one other final thing to keep in mind is, larger patients are going to be getting larger radiation doses from the camera, and steeper angulations of the camera are also going to be associated with higher radiation doses. So trying to avoid those when possible, steep angulations, and moving the camera around, not letting the radiation focus on one area of the skin to avoid high peak skin doses.